Good evening, everyone. We'll get started with the next session. This has been a long-running IC at AIOC, and we are here to teach all of you the basics of one of the challenging surgeries of cornea, which is Descemet's membrane endothelial keratoplasty, shortly called DMEK. We have a host of national faculty who are masters of DMEK, who are going to be participating in this course and will teach all of us the basics in a simple form so that everybody can understand what is going on. We're trying to avoid complicated jargon and complicated steps. We're going to break it down into simple steps, which hopefully all of you will be able to grasp. And if people haven't really started their journey of DMEK, hopefully this will be a motivation to get started. I'd like to invite my co-instructors on the stage, Dr. Rajesh Fogla, who's one of the pioneers of DMEK in our country at Apollo Eye Institute, Apollo Health City, Hyderabad. Dr. Vineet Joshi from LV Prasad Eye Institute. He's a young consultant doing a lot of good work in cornea. Dr. Siddharthan from Coimbatore. He's in private practice. Dr. Purva Shah Naran. She's from AIMS Nagpur. Request all of you to just come onto the dais so that we can get started with the IC. The first talk will be by myself. I'll just give a short introduction on DMEK, and then we'll talk about the instrumentation. After which, Dr. Vineet will talk about. Dr. Purva Shah is requested to speak earlier, so she will talk about the role of wet lab first, followed by the talk by Dr. Vineet Joshi on how to take care of the donor in DMEK. Dr. Siddharthan will tell us about the DMEK dance, ensuring how to get the DMEK graft the right way up. And finally, we have the master, Dr. Rajesh Fogla, who will teach us about difficult situations in DMEK and difficult conditions in DMEK and how to deal with them. So I'd like to introduce all our faculty. I think I've already given you a brief intro. All of them are brilliant surgeons doing a lot of good volume of DMEK and of course all other corneal surgeries, and I'm sure all of us will enjoy their videos and small pearls to start doing DMEK and understanding it better. Like I said, this is going to be the flow of talks, and we'll hopefully have about 10 minutes for discussion in the end. So what is DMEK? DMEK is Descemet's membrane endothelial keratoplasty. Now it has been a revolution in evolution, I would say. Posterior lamellar keratoplasty, deep lamellar endothelial keratoplasty, Descemet's stripping endothelial keratoplasty, Descemet's stripping automated endothelial keratoplasty, then came DMEK, and then a kind of a branch off of DMEK called PDEK, which is pre-Descemet's endothelial keratoplasty. So all of these are techniques for doing selective endothelial replacement. Currently, we're going to be addressing DMEK, which seems to be the one of the best solutions for treating isolated endothelial disease. It's been evolving. It's a revolution in evolution, I would say. And I think the next frontier is cultivation of endothelial cells, which has already started. And we may not even be doing endothelial grafts. We may just be injecting endothelial cells into the anterior chamber. And that should take care of endothelial disease in the future. So why should one be doing DMEK at all? DSEK was a beautiful surgery. We've been doing it for more than 1.5 decades or 2 decades now, and it gives very good results. Why DMEK at all? Because I think the one single reason to be doing DMEK is because the endothelial rejection rate is far lesser than even DSEK, which is much lesser than penetrating keratoplasty. It gives faster and slightly better visual recovery than DSEK. You will get more patients with 20/20 unaided in DMEK than you will get in DSEK for sure. A better understanding of surgical nuances has made the procedure more repeatable and more predictable. So the learning curve is becoming shorter because we've understood how to deal with DMEK much better, how to deal with the donor better, how to insert the graft into the eye and make it attach better. So the nuances, because of many people who've been doing it for the world over, giving us small tips, and courses like these, we are learning the small nuances, and surgery is becoming more predictable and repeatable. One of the key things in getting good results is to select your patients and your graft well. So donor selection is very important in DMEK. You have to avoid too young donors, especially in the earlier stages, because young donors, the endothelium, the descemes membrane tends to scroll up into a tight roll. It's called a cigar roll, and that can be sometimes difficult to open. Avoid diabetic donors while you're stripping, they can tear. Avoid donors where the fellow eye DMEK harvesting has been difficult, and you definitely want a good endothelial count in DMEK because there will be definitely a lot more tissue manipulation in DMEK compared to DSEK or PK, at least in the initial stages. So my cutoff is 2500 count at least. In the initial stages, it's also important to select your patients carefully. You want patients who have relatively clearer stroma so that you can see through to what is going on in the anterior chambers. You want reasonably good visibility. You want an intact iris and pupil. You don't want any vitreous or anterior synechia. Initially, it's better to avoid deep anterior chambers or soft eyes like aphakic or post-vitrectomized or post-filtering surgery eyes, because in these eyes, it's not so easy to unfold the donor because of the deep anterior chamber. How to get started on DMEK? I think wet lab is mandatory, and Dr. Purvasha will be covering that very soon. There's no short cut for this. You have to practice a lot. You have to practice a lot in the wet lab, and then even you will also have to go through your learning curve in your patients. Observe lots of videos. I think that this is one of the surgeries where seeing lots of videos does help. If possible, find a mentor who can give you some tips. Get trained if possible, and also observe them doing surgery live. Supervise surgery if it's possible, it's always better. So institutes have this luxury of this kind of training. Start with simple cases first: fuchs, clear stroma, intact pupil, etc. And AC should not be too deep, otherwise you will have difficulty in the beginning. So I'll just quickly touch upon instruments that are available. And I think this is one surgery where it really makes a difference to have the right instruments. So the instruments are related to the donor preparation as well as the recipient. The timer is not working. The trifines, donor related are trifines, instruments to elevate and strip the descemes, instruments for marking the descemes so that you can orient it correctly, and then tubes to insert, tubes or cannulas or glides or cartridges to insert the endothelial graft inside the eye. So 10 millimeters, the various techniques are followed. In the technique that I use, we make an initial trifine with a large diameter trifine. So a partial thickness trifine like this can be done to just cut the endothelium. You don't have to cut the entire cornea. So a 10 millimeter initial large trifine is required. You could use any form of trifine. It's good to have a guarded trifine, but you could also use a regular free handled trifine. You don't have to punch it all the way. You can just tap it to make sure that the descemes is cut. You also need these kind of small 3 millimeter skin biopsy trifines to make a window in the stroma for marking the anterior surface of the descemes. These are freely available in most of the surgical shops, and dermatologists use them all the time to do skin biopsies. You also need an 8 mm trifine for trifining the final cut of the DMEK scroll, and it's always good to have this kind of a punch trifine so that you get a proper centration. To elevate the descemes membrane, several instruments are available. You have specialized graspers which have wide tip like this, or you could just use a routine curve tie forceps, which is what I use. You can use one or two together. Initially, you can use a Sinskey hook or some sort of an instrument to elevate the edge, and then you use a forceps to grasp and strip. I think this is another instrument which is very useful. Some instrument with which you can put some sort of an asymmetric mark on the anterior surface of the descemes membrane after you made a window. So F stamp or an S stamp or a P stamp, or just you can use a Sinskey hook and you can stain it with gentian violet and mark over that as well. There are also instruments for the recipient. So instruments to score and strip the descemes, and then instruments by which you can manipulate the donor graft, you can insert the donor graft. So you have specialized glass cannulas like this available from various companies. Earlier we were having from DOC and Goida, but now many of the Indian companies are also making them, and they are pretty good. You also can use a homemade injector like this. This has been devised by Dr. Siddharthan, and several others use IOL cartridges, etc. So any instrument through which you can see and safely insert the DM scroll. You can use these kind of IOL trays as the carrier to kind of load the graft in. So these work as well, but a glass inserter is less traumatic. This is a very interesting instrument which was developed by Dr. Fogla, and basically it's got kind of a retro illumination, so you can see the stripping of the Desmase very well because of that retro illumination from the back. So basically it's a artificial anterior chamber with a light behind it, which provides a good backlight to do all your steps. It's made by Coronet. So we'll move on to the next talk. Dr. Purva Shah is requested to speak earlier because she needs to go to another session soon. She will tell us about the role of wet lab in learning DMEK, followed by which Dr. Vineet Joshi will talk about donor preparation for DMEK.
Until Dr. Purvasha just said some really amazing talk, Dr. Rishi, and I think you showed a very nice spectrum of all the instruments done at all the levels across like globally, and also what we can try in wet labs, which Purvasha will anyways show. But very nice the trick, the earliest, the first surgery if you want to do, and we all tried with the IOL cartridges. And so, which IOL cartridge do you prefer the most in that case?
I don't use a IOL cartridge for DMEK. I use a glass injector because I feel that goes in more atraumatically.
Okay.
And these are not very expensive now. Earlier they were difficult to procure.
Now we have a lot of Indian manufacturers also in glass tubes, so we are like doing good. So I think Purvasha is ready with the talk. You can go ahead.
Right. So thank you, Dr. Rishi and Dr. Vikas Mittal for giving me this opportunity to be a part of this instruction course on DMEK. Um, so as we know, Desmos membrane endothelial keratoplasty is a very delicate surgery. It's a complex surgery, and it's just a 10 to 20 micron tissue that we are dealing with, and we need to be careful, and all the nuances and the skill sets need to be understood to give a successful outcome and to prevent the endothelial cell loss and the ultimate visual outcome. So dealing with this tissue, we should be very careful, and it is kind of sometimes difficult for a novice surgeon or even for those who are transitioning from DSEC to DMEK. So it could be that we practice on the tissue which is discarded, which is the human discarded eye bank tissue, but just before that, to develop the macro and the micro reflexes or the tactile stimuli to deal with different types of the dealings of the DM, it's better to practice on certain tools or models or props beforehand. So based on the study, which tried to identify the key challenges while trying to learn DMEK surgery, DM donor preparation, DM graft insertion, and graft unfolding in the anterior chamber was found to be, these steps were found to be the most challenging ones. So what can we do about it, and how do we begin right? So an ideal model or a prop should mimic the feel of the real tissue in real time, and should give the feel of the surgery, the exact feel. It should be affordable and easy to set up. So based on different steps of the surgery, we tried to devise certain models, and we've even published them. So looking at the graft preparation, this is the model that we have described, and this is actually the humble onion peel model, or the onion that is seen in our kitchen. We can take a peel of it and then place it on the Teflon block, and then it peels exactly like the actual Desmase membrane. It also stains like one. You can practice partial definition, you can practice stamping, you can practice its scrolls, you can practice how to punch it and then place it upside down and then peel it off completely. And this is how you develop the reflexes based upon the onion tissue. So you dry the well, and then you can even stamp it with the preferred letter P, F, S, L, whatever you prefer, and that is going to give you the exact feel of the tissue. After you're done with that, we can even prepare a scroll, inject it into the inserter, and place it into the practice eye tissue or the artificial plastic models that are available mounted onto the anterior chamber, artificial anterior chambers that are present, and can also practice the various maneuvers to open it. That's the thing that I was talking about. Right. So the next step is understanding the orientation of the DM graft inside the injector, and for that we have devised this large bore glass syringe with a bevel, and for that a plastic sheet with a printed endothelium on one side and a P marked on the stromal side gives us the orientation of how the graft should be placed. And if we insert the DM graft with the bevel up, this is the orientation which is seen, and the stromal side is seen in the correct orientation, and the graft opens in its proper place, and the P is seen the way it should be. And if we inject it with the bevel up, this is the way that the endothelial side will be seen, and we need to then understand that we need to invert the tissue. Inside the anterior chamber, there is fluid, and the DM is a very thin, delicate membrane, so we need to understand how to manipulate it, which is very different than the tissue manipulations with Desmais stripping endothelial keratoplasty or the DSEK. So we've published a DMEK aquarium, and this is made by using a transparent plastic balloon, and which is filled up with water and a plastic sheet or a scroll which mimics the DM graft, and that is how it's prepared. It's filled with water, then the scroll is pushed inside, and then it's sealed with a rubber band. So that's a frugal use of that tissue, which you can get it from your laboratory shops. And then it even gives it mimics the handling of the tissue within the anterior chamber. These are waves that are created for crude centration of the graft using two cannulae, which can be mimicked by using two fingers to displace the graft to the desired side. You can also practice the unfolding of the graft, the pinning maneuver, as well as the inversion of the graft. This is another model which has been described, and this is the artificial anterior chamber over which we place the piece of a rubber latex glove and then prepare an anterior chamber mimicking the iris diaphragm, and all the practices of the dosa roll, the chapati roll, all unfolding and centration can be practiced in the discarded human tissue. So this is another wet lab model that we have devised. This will help us achieve desired outcome. So the suggested plan for surgeons starting to learn DMEK is what we suggest is watch videos as much as possible, as has been already described by Dr. Rishi. Then try on the onion peel model, try the DMEK aquarium, get the skill set of dealing with the DM nuances in the anterior chamber. Use discarded human eye bank tissues and practice on the surgical wet lab for a few cases, and then ultimately perform the first few cases preferably under the supervision of a skilled mentor, or one may even record your surgeries and then discuss with a person with an experienced DMEK surgeon. So these are a few of our wet labs that we had conducted a workshop in for DMEK at various places, and these are the tissues that the trainees had worked upon. The main ingredient for a good wet lab is an enthusiastic mentor who is ready to keenly observe what you're doing and is ready to share his knowledge with you. And the satisfaction that we achieve after imparting the knowledge to this trainee is evident with both the smiles of the mentor as well as the mentee. So we even do post-wet lab or post-workshop questionnaires which tell us that 85 to 86% of our trainees were very happy and confident to start with the actual DMEK surgery. And this is the final outcome of the workshop, wherein people post their first cases of DMEK, which they have managed to do on their own, and then they can even continue to discuss their troubles or their problems post-operatively. So that's the tools and tricks of the armamentarium for the learning the DMEK surgery. Thank you so much. You're welcome, Rishi.
Thank you, Purvasha. I think you really beautifully covered the entire spectrum of wet lab practice, and I think it's very useful because people sometimes don't have access to corneal tissue. With your techniques, they can practice even without having access to an artificial anterior chamber or corneal tissue. You can just do these simple steps as long as you have a microscope. Onions are freely available, thankfully, even in times of drought. And I think this is a really good innovation by you and Vikas to try to use the onion peel as one of the layers, and you can practice everything how beautifully you've shown. So thank you for
Thank
sharing
you so
that.
much.
I'll invite the next speaker, Dr. Vineet Joshi from LV Prasad Eye Institute, and he's going to tell us how to get the donor dissection right. This is not the correct talk.
Yeah. Can you load my presentation, please? Yep. Until he loads, I think very nice talk, Purvasha. It was really amazing, especially the onion peel technique. And just when I was touching base on the IOL cartridge, we use the AMO 3-piece IOL cartridge, and we cut off the edge of it to. Let's see. Okay. Okay. Thank you.
Are there any questions from the audience? It's nice that the attendance has built up a little. Dr. Fogla, please join us. Okay. Any comments, sir? Can we have mics here, please?
In terms of practicing the decimates, we did a lot of research to try and figure out what actually simulates. But till now, I have not found anything that will tear as easily as the decimates. The onion peel is good to understand the basic concept of what you do.
Right.
But the difficult part is that it doesn't
easy to tear,
Like
yeah.
you can just peel it off confidently.
Right.
But unlike a decimates, when you do in eye-bank corneas, you realize that it's very fragile. So that for people, trainees to learn, because one of the difficulties people face is preparing the donor.
Do you
They
think
always-
a capsulorhexis would work?
No,
Have
even
you tried
even the anterior capsule we tried, it is still thicker than the decimates.
Right.
Maybe it will tear. And the other problem with the onion is that you can't practice unfolding with it.
Right.
You can get it to scroll, that's fine, but you cannot push it inside an injector. And
Right. It behaves
anterior
differently.
capsule can be tried. You can from femtocataracts if you
Right.
get the, but that's too small. It's usually a 5.5.
5.5, yeah. But
So
at
it-
least maybe you can get some idea of.
You can, it stains with trypan blue very well, and you
Yeah.
can still inject it into the eye, but it won't curl exactly like a DM. So, but I think to understand the basic concept at a micro or a macro level, these are all the things that we can use to basically explain them before they go ahead and mess up a lot of donor corneas. So at least
Have you tried taking Desmates from animal eyes?
not really, but again, like I say that from pig's eyes, if you try to take the decimates, it's difficult to peel. And if you peel also, it's too elastic. It goes into a very tight scroll. So it doesn't
Right.
simulate the one that you want with the.
So it's been described in goat eyes, but it doesn't peel off very well. It's very adherent.
Very adherent.
And it's a very large Desmet scroll
It's
in
a
goat
very
size, so
large.
it's very
You can always
yeah,
punch it
You
out,
can
but the
always
problem
punch it
is
to
it goes
size,
into a very tight scroll.
tight scroll.
So unfolding part.
Thank you. Are you ready?
Yes. Yes. So, fantastic talk. So, thank you, Dr. Rishi, for covering some important parts of this. So, I can directly skip to the donor preparation. So, an ideal donor should be whenever you're starting first few cases. It's better if we choose a donor tissue with a donor age of around 50 to 65 years, because the lesser the age, the tissue tends to be it scrolls tighter, and it is very difficult to strip in the initial days when you start your first few cases. And I would. It's good to have slightly smaller size scrolls rather than doing larger scrolls more than 8.25 or 8.5 mm. 8 mm is very good. You can also try 7.75 to begin with at a safer side. And better take tissues stored in MK media, because they are easier to scroll, easier to strip compared to the cortisol. And always check, if preferably if the donor is phakic, that's much better. The tissue tends to be less fragile. And if it is pseudo phakic, if you have no other option, always examine the sides wherever there is an incision entry for side port or main port, and avoid including that in your trifine. So this is already covered by Dr. Rishi, and I will be talking about, there are many techniques in donor preparation. But to begin with, in your earlier days, a simplest technique is double punch technique. And I'll just take you through some videos. One video I will just show you overall what all the steps involved, and then we can focus on each and every step as quickly as we can. So in first and foremost, it's important to center the graft, as we just marked it with the marking pen, so that you can take a suction trifine and center it properly with that mark to the center of the trifine. Then going ahead, it's if you have a suction trifine, very good, you can apply suction at this point of time. Even if you don't have a suction trifine, you can go ahead with a madhu trifine. But the trick here is delivering the right amount of pressure when you give the taps. So if you have a coronet trifine, which are difficult to get by now at this point of time, this is a very good trifine. So what I do usually is, you can just rest it on the endothelium and just tap it, maybe from the the terminal phalanx, and tap it all 360 degrees round and round, and then keep rotating your anterior chamber so that you cover it 360-degree. Gentle taps. But when you are in your earlier days, I would recommend the taps to be little firmer, because it is always problematic if the descemex doesn't cut through. Then you stain with trypan blue and check how is the cut. So here you can see your cut. Here I have deliberately taken this video to show that it was slightly eccentric, and that is because the scleral rim in this video was large. So when I put the guard, the graft has gone little bit to the other side. So even in these cases, how the double punch technique is useful, I'll show that. So now you can see that trypan blue has actually marked the size where it has cut through. So using a normal Sinskey hook, I'm just trying to see if it has raised the peripheral frill. Now this is the area where I'm not seeing the staining. So naturally this has gone to the periphery where there are thicker adhesions. So I'm just trying to see if any area is loose over here, and if not, you can actually score it again with the same Sinskey hook in that area and try to raise that peripheral frill. Now comes removing this peripheral descemex beyond the margin of your strip cut. So this is very useful, because when you remove this peripheral descemex, the actual peripheral edge of your scroll starts freely floating within the fluid, and that is what you want. You want the graft centrally attached, and then the peripheral frill to float in the fluid, so that it gives you that grip to hold with a, this is a curved tying forceps, titanium tying forceps, and to hold it at one edge and then start stripping. So if while stripping, it is important to maintain and see a straight line here. It is slightly out of focus, I'll show it in the next video. And once you strip it, keep the central area well attached. Do not strip it beyond that area. So you can do it at 3 main regions, and keep the central attached. Now comes the second punch. So this is the area where, if you have gone wrong in the initial step, if there are any tears and tags, you can exclude that area and fit in the healthier region within this 8mm graft and tap. Again, gentle taps, and strain it again, so that excess rim between the 9.5 and the 8 mm trifine usually comes off very easily. So scroll preparation and overall DMEK is all a game of fluids. And here is where you should apply no touch technique, where you should use the Vexel sponge wisely to move your graft fold or unfold onto itself without touching it too much. So now I have done a 50-50 fold where I have folded it onto itself, so as a bare stroma is exposed, and using the 3 mm Trifine as shown by Dr. Rishi, we punch a hole so that this stromal cap will help us in marking the tissue. Now there are various new methods like the BCL technique and all, where you can prevent this particular step and save the tissue for any other stromal lamellar transplants. But this is for in the beginning stages. It's very safe to get a very good mark, because a mark is very important in the initial learning stages. Again, if you see there is excess of fluid, the graft will tend to keep floating. So in this case, it is very important that you use the Vexel sponge, push the tissue or tilt the anterior chamber in a way that the fluid is drained downwards with gravity, and drain it with the Vexel sponge. With the fluid current, the graft will fall back. Again, this window which is cut through, it has to be fully dried with the help of Vexel sponge. Reason beyond, we don't want the mark to smudge. And a tip here, the fluid will tend to seep again and again through the peripheral edges. So keep drying it with a new Vexel sponge tip until you see that pitted appearance in the base of the the DUAS layer on top. So you can mark any asymmetric letter of your choice, but make sure it does not smudge. That's the most important thing, because you want it to remain its morphology until it is inside the anterior chamber and the graft is unfolded, which will be covered by Dr. Siddhartha. So once this is done, please dry the undersurface of the cap as well, and then place it back, otherwise this smudges very badly. And once this is done, you can go ahead with staining the graft. Now this you can do a trypan blue stain for 3 minutes or so. You can also use brilliant blue, that is you can actually use it only for 1 to 2 minutes. It's a stronger stain. And some say that if you there is some form of cross linking that happens, but there are elastin fibers, so probably the light source is also working in any way. I don't know, these are all as hypothesis. But once separated, you can free float the scroll into the bath, and then take it within your syringe to float. So I think we covered most of it. I'll thank Dr. Praveen to giving some of these videos. I just wanted to show some complex situations. So this is how you should strip the peripheral skirt, so that it becomes very easy to actually lift the graft at the edge. So I'll just forward and I'll show you. Yeah, so this is the free floating skirt. This is exactly what you want when you start holding the peripheral frill with your forceps. And strip it 1 clock hour at a time. Do not rush. Do not the pull has to be initially it can be tangential, and then pull it towards the center slightly, because this is just frill elevation, this is not stripping. And if you feel there are any adhesions, go slowly and try to peel it until it is fully separate. If you are not able to go around it, just go from the other side, so that you are not you can avoid a tear in those cases. So if at all there is a tear, you can anticipate these areas wherever the trypan blue doesn't stain well, or if the graft's age is more than 65, or if it is pseudophakic. And if it is very brittle, you will feel it. I mean, as soon as you hold, it will start cracking. So change the site from where you are trying to attempt to strip, and try to get an area where you're getting a free edge that is strong enough to hold and strip clearly. Okay, thank you. I think that's time up, and I'll stop here. Thank you.
Thank you, Vineet. Those were some really nice videos, and I think you put the point across very well. What would you do if during the process of trying to harvest your graft, you end up damaging, say, about 30-40% of it, would you still proceed to try and complete it as a DMEK, or I think you guys don't have that problem because you have an eye bank and you always have backup tissue. But for a person who doesn't have, what would you suggest?
If it is a radial tear, and if your initial trephine is around 10 and if there is a possibility you can decenter it and get away with a 7.5, 7.75, very good. But usually such maneuvers, I mean, what I have seen, you actually end up manipulating too much, and that actually because it doesn't go pretty well, but still you can manage. There is a good side. Hope is that when you're decentering it, you're actually taking a side with more endothelial cell count. So there are plus and minuses to the both. But if it is a radial tear, why, you can always circle it out like a rexis. While doing that, if you feel that the remaining tissue is good enough, large enough to form a scroll, then it's okay. Otherwise you might have to abandon.
More hypothetical situation. In fact, I've faced that situation several times. When you're trying to strip and right at the periphery, it starts just tearing. It's very fragile. Now you have not come very central. You're still peripheral. You still have the chance to do a DSEK instead of a DMEK.
Yes.
So do you think it's a good idea to, if
Oh,
you
yes.
start seeing that kind of a situation, to
Definitely, you can do. And in fact, even if that small Descemet's detachment stays, the DSEK graft will survive. It will
Yes.
not fail, or it will not matter.
What if you've partially stripped it and then you decide to do a DSEK?
I don't
Maybe.
know. Might work. I don't know.
Please come to the mic and share your experience.
So if you have like a radial tear, what you do is that you get the graft and you put it into artificial anterior chamber, and then you get your DMEK tissue, whatever the way you want, manual or with a microkeratome. But the issue is that you keep the torn part of the DMEK tissue in the upper part of the anterior chamber, so that it's supported with the air bubble, especially if it's expansile gas, for a very long time. And this will have like a scaffold where the tissue attaches very easily to the rest of the stroma.
I think that's a great idea. So please introduce yourself for the audience to know who you are.
My name is Hazem Yassin. I'm a professor in Cairo University, Egypt.
Thank you.
You're welcome.
Thank you, sir. Thank you so much.
And a student of Dr. Rajesh Fogler.
All of us are his students. Dr. Fogla has something to share.
You can always, if you have a radial tear and you feel that that segment of the DM you're going to abandon or you're going to tear it off, then instead of punching a 8, you can punch 8.5 or 9, so that you have a much larger, so the amount of transplanted endothelial cells, the volume increases.
Yes.
So you can always, if your anterior chamber volume allows, punch a larger graft size, so that even a loss of a 20% of tissue is compensated
Yes.
by the larger diameter of the.
Fantastic. Yes.
Yes.
Another adding for those patients which you get the graft while they are pseudophakic. So sometimes the tunnel of the corneal incision is big and it might interfere with the separation of the DMEK tissue. So what you do is that you inspect the cornea from the beginning, and then you leave that part where the corneal incision is there and keep it as if it is the hinge where you cut through, and you don't have to go through the wound, otherwise you will induce the radial tears many times.
I think that's a very good idea, and perhaps when our eye banks are sending us these tissues also, they could try and figure out the wound area and mark it. You can just see it, yeah. Cuts. Right.
Can see
So I
that.
think that's a very, very good tip, and we could be mindful of that. as
Yes.
well.
Thank you.
Thank you. Thank you very much. We'll move on to the next speaker, Dr. Siddharthan, again a young dynamic corneal surgeon from Coimbatore. He has been an early adopter of DMEK, and he has some beautiful videos and nice innovations in DMEK, and I'm sure we'll all enjoy his talk. He's going to tell us about the DMEK dance, ensuring the graft is the right way up.
Thank you, Rishi. So I think you saw very beautiful videos of how it's being prepared, and There are many methods. In same way, ensuring the graft the right way, there are many methods, and the way you unfold, there's a lot of transformation being happened. So just for the beginners, so why DMAC is a little bit difficult. It's not a difficult steep learning curve, is because you see that the endothelium always scrolls on itself, means that the endothelium cells are outside. So the manipulation, when you do more, you get a lot of damage in these endothelial cells, and that's why you have a lot of failures. So this is just a real-time video where you can put the DM as a taco fold as you do in DSAC. So in DSAC it stays, the endothelium is very safe inside, but you see here the DM snaps open and the endothelium is exposed. So this is pretty difficult, and that is why when you take it in the glass syringe or any syringe, there are a lot of damage, and this is why it puts people behind. When they're doing very good DSAC, they don't want to move over to DMAC, because when they see 2-3 failures, it becomes difficult. So the mark. So the mark, initially when we started in very early, we never had this mark, but in around 2014-15 we started marking. So mark can be any way, L, P, F, whatever. So I just initially did a very simple L mark, meaning there's a small horizontal mark and a long vertical mark. So basically our corneas are pretty hazy when in India when we do. So seeing multiple lines is pretty difficult. So I always see that the mark, the short horizontal limb is always on the right side. Whichever portion it goes, I just see the mark, whether the mark is on the right side of the vertical mark. That's the only thing I see. Sometimes cornea is very hazy, you won't be able to appreciate the other details. So before going into the unscrolling, there are very important steps you have to understand. The first is the tunnel size. So when you have a difficulty in the injection of the DM, uh, here I'm trying to inject it inside, I'm trying to inject saline and all these things. You see that the graft is moving, and meaning that there is no space for the fluid to move out when you inject. So this is a 2.8 microkeratome, I made it 3. Ready, you have to make the eye soft little bit. You unscrew the speculum, and now you can see that it very nicely goes in, and it goes in. So never inject before the exact edge of your injector goes in, otherwise you will have a lot of issues. Second, sizing is very important, because for example this patient is having almost a 5.56 mm pupil, and I've taken a 7 mm graft. These were all initial days, so it is very difficult to unfold this, because it keeps sticking on the fibrosed anterior capsule, the lens, and into the rim. So what you should do is, when you in this larger pupil, the key is take a larger sized graft, meaning that you see that the edges acts as a fulcrum. You see that it goes beyond the pupillary margin, and once it touches the iris, it very beautifully unfolds. So even larger pupils, take a larger graft, and make sure that your graft size is slightly bigger than your pupil size. So this is very, very important. When this says, if I had taken a 7 mm or 7.5 mm graft, it would have got caught inside and it would have never unfolded. And when you start your cases, in initial cases, don't take young donors. In 2013-14, we used to be very heroic. This was what all should not be done. We did mean that it's a young tissue, 30-year-old tissue, vitaminized eye, iris claw was done. So all these things, if when you start and you start to struggle, your confidence level comes down. So somehow we try to unfold all these things, but ultimately the amount of endothelial damage will be very high. So never in your early cases take good pseudophakic cases with the IOL in the bag, not much of scarring, and you take the tissue which is around 50 to 60 years old. So you can see that when you take slightly elderly tissue, the tissues is really ready to unfold. So when you are starting your DMEK, when you very fresh first 10 to 15 cases, take above 60 to 65. So it very easily unfolds. You see that once you inject, it unfolds, and slowly you will when you start getting confidence, you can slowly move over to 40, 45 or 50. But when you start, I would suggest you to start with a 60. So unfolding techniques, it has been evolved over a period of time, but there are certain rules. Means that once you inject, always put one suture before you manipulate. That is very, very important, because when you try to, even though it is a little bit around 50-60% unfolded, we'll be tempted to go inside and inject and unfold. But always try to apply a suture in your initial days. And then before, what we used to do is inject saline, make it real like a DM dance. Like we put so much of saline, tap, a lot of tapping used to be done in the previous methods, like, and we really never had much control. Meaning that you tap, you little bit make the AC shallow, you tap. And this tapping was the initial days when we were doing the DMEK, when it was in the early 2013-14, and you see that the L mark is very nicely seen. So you even tap gently to reposition the graft, and then air is given. So after this, we sometimes use a two-hand technique, meaning that we can use two hydro cannulas over the cornea. So you can see that with two hydro cannulas, I'm just injecting some saline, making it shallow, and then just gentle tapping, it opens. So even this, a very gentle tap, no need to make very hard taps, gentle taps, shallow, so that it moves exactly to the position. You can see the mark, L mark, and then you can inject. So these were the techniques we used to do before. And but what happens is, sometimes, not that all the times, these techniques, when you put a lot of saline, you keep shallowing, it doesn't always unfold. You can see here, I'm trying to do with the same hydro cannula. So this was sometimes, it used to take a lot of time. So nowadays we don't do all these things. We do something known as a hold and release technique. With left hand, you hold the periphery of the DM, and the wound, you inject saline and shallow. You inject saline and shallow. You see it open. So you have a very good control of the DM unfolding, rather than you tapping violently or with two hydro cannulas. This is very simple. Hold with your left hand the periphery, inject saline shallow, and you will be able to get very good markings. So how sometimes what happens is, it gets unscrolled the wrong way. So how do you unfold it uh, when it is in the wrong side? So this was an IOL explantation done, and an iris claw lens. I put an iris claw lens, and then after putting two sutures, I injected and I put a suture. So in this case, what happens is, you have to closely observe here that it is unscrolled on the wrong side. So what I do is, you have to inject. See, I now realize that it's on the wrong side. So now you should inject saline underneath the flap. Means see the underneath of the flap. When I'm injecting saline, it is moving up. It is slowly, it moves up. You see, as I inject, keep seeing the inner side of the flap, how it flaps up. See how it flapped up. You see how this flapped up to that portion, because I was injecting. So now I hold that and I release it. So when it's in the wrong side, it is very you should put the saline under the graft. See, in this video it will be very clear. Keep once I inject saline, keep look. I try to unfold. I see that the L mark is on the wrong side. See, it is on the left side, the horizontal mark. So you see, now I'm injecting saline underneath, under the flap. You look at this, suddenly see how the inner flap unfolds up. So you keep injecting the saline under the flap, and you see that it moves, the flap moves up, and it's very simple, and you can see the L mark now very clearly. So these are some techniques. Rather than too much of going and manipulating, just with saline and fluidics, if you move, it is very simple to be done. So just one or two videos of how to hold, and most of the times we can try to put the graft on the proper orientation. Not that every time you want to put it on the correct side and take it, because most of the time when you inject it inside, you will not have control of which side it goes, unless you are using a glass syringe and holding it from the other side and pulling it. Most of the times I try to keep the L straight to myself and then I inject. And again, just wanted to show you the method of what we do now. Hold with the left side, inject saline, shallow it, and then you see that how beautifully it unfolds. So just push it very gently to that position. Hold with your left, the hydrocannula, inject saline, keep inject saline, and you see that it folds. So you have a very good control over this thing, and you can see that very gentle taps. Don't make very hard taps, very gentle taps, it unfolds. Another video, the key here is make the graft horizontal, make the graft horizontal to yourself. See, this graft is vertical, it is difficult to unfold vertically. So make sure that you push the graft horizontally so that your left hand will be able to adjust. So here I'm just making the graft horizontal, and then again injecting saline and shallowing it, and you can see that we can, once the graft is little bit unfolded, with the left hand you can actually push the graft to the other side. See, it moves very well. And then once it is done, hold and inject. So hold and release is the technique which now it's very easy, and it takes 2 to 5 minutes to unfold your grafts. So the other techniques are just the same. So one more key point is, if in regrafts, what I have learnt is, before this, in this graft I had taken a larger graft, meaning that I thought the graft host junction was 7.5. I have taken a 8 mm graft. So it's very difficult to unfold a graft in a regraft taking a size larger, because the graft host junction is very irregular. So it will not get opposed in that portion. So it will be very difficult to get opposed. So here somehow we try to adjust and do it, but if you take a smaller graft, if the graft size is 7.758, take a 0.25 lesser, so that it very nicely goes and sits inside the graft host junction, and it will be very easy to unfold. So these are some of the key points and in unfolding the graft, and I hope much more interesting videos I think Dr. Rajesh Fogla will be able to share with you. Thank you.
Thank you, Siddharth. And I've seen your videos so many times, and you have some comments, and they keep getting better. I think your technique is very different from what we routinely follow, and there's lots of learnings for all of us. I think the way you hold the graft down, pin it down, and then you're going through such a big wound, and you're not afraid that the graft will come out because you pinned it down to the iris.
Yeah.
And I think that's quite good. You're not doing much of tapping or drumming.
Nothing.
You're just putting in fluid, egress, again and again. And because you have a big wound, you have a lot of working space because of that.
You inject saline shallow, inject saline shallow.
Yeah, very interesting. Thank you.
Yeah.
Yes.
One of the very challenging cases, and I always remind myself, asking those patients who are going to do DMEK, is there a possibility that they are potential IFIS syndrome, even if they are females? Because sometimes they are on alpha agonist, and you try to inject your cannula. Once you go inside, you find the iris is prolapsing. If you're trying to drain from the side ports, the tissue is there, and what's going out is the iris. So a very important issue that you discuss with the patient, even if females, if they are on alpha agonist or no, because it's very challenging in such a situation.
That is such an amazing point, and thank you for bringing it out. And I think all of us have to be mindful of that, because many of these patients of DMEK that we are doing are pseudophakic bullous keratopathies, and these are patients who are likely to be on alpha agonists. Thank you for bringing that up, and I think all of us should be mindful of that.
So when you're doing pseudophakic bullous keratopathy with a corneal edema, just think of the cataract surgeon and understand that he's a good cataract surgeon.
Yes,
and the cornea became edematous because he has had some problem during surgery.
Exactly.
So planning surgery, expect the unexpected.
Yes. I think the next speaker needs no introduction. Dr. Fogla is the teacher of teachers. He's taught all of us DMEK. He's one of the pioneers in India for this particular surgery and many more. He's got some great innovations in instrumentation for DALC and DMEK. And who better than him to teach us about challenging cases in DMEK?
So with all the courses that we have been running for the past almost 15 years, and so many people we have trained, now in my practice, I sometimes wait to see a simple case, because all of these guys are doing all the simple DMEKs. So all the ones that come into my practice are the challenging ones only. So as we mentioned, torn DM, yes, when you are starting off, at times you can get diabetic donors where there are abnormal adhesions, and you start off with one quadrant, you move to the next quadrant, and every quadrant you create a small tear, you wish that the other quadrant will be okay. And finally you end up with something like that. Either you have a large horseshoe tear, or you have just that kind of a large peripheral orange peel, and then you are thinking what to do. Luckily, Melis has published hemi DMEK and quarter DMEK. So you just think of him and you say, okay, fine, we are okay. So this is a patient where I had already stripped the host DM 8.5 millimeter, and I went to prepare my donor, and I had a donor graft that was only about 40% of it left, and I had no backup tissue. So I said, okay, this is what is in patient's luck today. So went ahead, and no stamp. So I had to fall back on just looking at the edges and then deciding which is the right side. So we put the graft into the eye, but what we attempted was to try and place the graft in the center of the cornea, so it should cover the pupillary area. Otherwise, patient will tend to have edema in the area devoid of DM. So so you can hear part of OPL as well, So we placed the graft successfully, put a large air bubble, and then I thought, let's see. In the immediate post-operative period, you can see that the central part where the graft is with the dotted line, the cornea looks reasonably clear, but there is peripheral edema around where there are bare stroma. I was thinking this is going to take a long time to clear, but 1 month later when the patient came back, he came back with a box of sweets. He was 6'9", unaided. And when I looked at his cornea, I had to go back to the surgical records and see whether it's the same patient. So I think some of these patients have good reserve of endothelial cells in the periphery. So that's why don't be very aggressive in doing a very large DM stripping if you have the peripheral DM which are devoid of guttae, because you go ahead and you say that I will really going to remove.
Can I interrupt you?
Yes.
In this case, did you strip a smaller area in the
No, I had
recipient?
already done 8.5.
Oh, you had already done
because
that.
I was planning a 8 millimeter graft.
Right, okay.
But the other thing that you should do in this case, besides giving hyperosmotics, is you can try putting them on rho kinase inhibitors.
Yes.
Just like we take from DSO or DWEK, where they give rho kinase inhibitors to speed up the process of migration of cells. So here, both from the graft cells migrating out or from the periphery cells migrating in, they may cover the defect much faster. So patient will not have a persistent edema in the periphery. And this is another patient where you are peeling. That's why I don't like to hold my graft with a second instrument. I always use just a single-handed technique. I also don't recommend using a vacuum because that fixes your graft below. So your tendency of feeling that resistance as you're peeling, you won't feel because here, because you're not holding it, when you can encounter a resistance, the whole corneoscleral rim will move. So you know that there is an abnormal resistance. We did stain in between to help identify the part which is torn. Then you started dissection from the opposite end. And then you created the stromal window, put in the F stamp, and now you can see that I am bringing it to the part where we had the horseshoe tear. I was able to complete that. That's where the horseshoe tear is. You see that? That can be easily nudged with a Sinskey hook as well. So there was a radial tear, just like we were discussing some time back. I stained it. You can see I punched out 8 millimeter, but you can see the radial tear. I always like to put the tear at the trailing edge. So the leading edge should be continuous so that, that doesn't get because it gets stuck in the iris, then sometimes unfolding becomes difficult. If it is closer to your wound, maybe you can go in and manipulate with your instrument, which is easier. And you should stain it well so that you can see your graft much better. So here you can see that we got the scroll in the right orientation with the open end of the scroll facing up and use the same tapping technique. You can see that the rest of the graft opens up pretty fast, but the part where you have the radial tear, there are two areas. You can see that. So if the tag is too thin and it's likely to get entangled, I would rather sacrifice it before I put it into the eye. But if I feel that it's a fairly large chunk and it should open up, then I leave it. Because a thin tag will have more tendency to get entangled, whereas if you have a large tag, then that is likely to unfold. So here you can see that we are able to successfully open up the graft using the tapping technique. Always use two cannulas. One is to stabilize the part of the DM that's already opened up, and the other one just to gently tap either within or outside the graft. Now you can see that even the torn bit is settled down like a jigsaw puzzle, and then you put in your air bubble and you are done with this case. So here you can see that that's the patient post-op. You can see by 2 weeks the cornea is absolutely clear. You can't even make out where you had the radial tear. This is what Rishi already showed you. We are still awaiting. COVID delayed the production of this. The patent has been filed. So I think maybe in the next 6 months, we will see production of this illuminated endothelial punch, where visualization of the decimates is really good. And if you do encounter any, like the previous cataract surgery incisions or any scars, you will be able to see them much more earlier than what you do in your routine cases. Now, the other thing that we come across, so this is a case where I was supervising this case and the surgery was going on pretty well, and we were tapping and we thought that we are almost coming to the end. The stain on the DM donor is a little faint because of prolonged manipulation and irrigation. Just towards the end, when we thought everything was okay and we are just going to put an air bubble, the inferior peripheral iridectomy started bleeding. And no matter what we did after that, that bleeding didn't stop. So, by the time I switched over and I said, okay, now let me take over and finish that, I think the case was already finished. Because I went in, by then you had fibrin formation in the periphery. So when you have bleeding at that point of time, either you should just try and unfold the graft as much as possible and put an air bubble. Doesn't matter whether your graft is absolutely well centered or is completely opened up, because once you get a big clot of blood in the anterior chamber, it's very difficult. And then we were trying to wash out the blood. We spent a lot of time trying all the maneuvers, and finally we had to give up and bring the graft out of the eye. And because the patient's local anesthesia started wearing off, she was straining her eye. And you can see the more we were manipulating, she was straining even more. Both the surgeon and the patient were getting agitated. And finally we had to call it a day and say that, okay, we're just going to remove the graft, put a large air bubble, and come back again. So sometimes when you have bleeding and if you can manage, well and good. But if you cannot, I think you have to put in a large air bubble and control the bleeding. If you have not put in your graft, then it's fine. A large air bubble, control the bleeding, then go back in. But with the donor tissue inside the eye, it can be a bit challenging. So this is, we went back 2 days later, the same eye, but we make a separate incision because the previous incision that was made, that was not like the perfect incision. That's why you see a lot of sutures that had been placed. Here we introduce the graft into the eye. Make sure that these patients are not on anticoagulant therapy, because a lot of these patients, sometimes if they are taking anticoagulants and you think that they have stopped the medication for 2 or 3 days and it should be sufficient, that may not be the case. Fortunately, there was no recurrent bleeding from the PI 2 or 3 days later, because patients are not willing to wait. They have this surgery, then they want, when can you do it next? But ideally, you should give it about a week's time and then go back in and do the surgery. So this is where we did the surgery. This patient did well. She recovered unaided 2030, improving to 2020. This is another scenario where you have a patient with pseudophakic bullous keratopathy and there is a large YAG capsulotomy opening, And every time you shallow the chamber, there is a risk that if the YAG capsulotomy opening is really big, you can have the vitreous herniating into the anterior chamber. So watch this video. I put in my graft into the eye. I usually like to use an AC maintainer where I stop it, and so by the time I did that, I come out, I can see that there is already a bead of vitreous that's coming to the main wound. That's because I shallowed the chamber and that the vitreous came forward and through that opening. So I just did a dry vitrectomy. I again formed the chamber with fluid, the vitreous went back. But as you're tapping and you're trying to unfold the graft, you release some fluid from the side port to help unfolding the graft. And you can again see there is peaking of the iris towards the side port and the main wound. So we went back, again did a little bit of sponge vitrectomy. And you see every time you do that, the pupil kind of goes back, becomes round. That tells you that the strand of vitreous has gone back. And then we gently tapped and we opened up the graft and we completed the surgery. You will see that at this end. So don't try to shallow the chamber too much, keep it formed, really reduce the pressure from the speculum so that there is no posterior pressure. And so the donor was covering the pupil, so even if the vitreous comes, it will not be shifting the graft. Finally, we managed to open it. It was the right orientation, put an air bubble, and the patient did very well. Now, in this kind of scenario, with the graft inside the eye, doing a vitrectomy can be very challenging because if you do it from the anterior chamber, the moment there's a very big tendency that it can get caught into your cutter. And if you try to do a pars plana, you might pull the graft into the vitreous cavity. So sometimes it's important to recognize this, and if you feel that before you put in the graft, maybe try and shallow the chamber, do a good wash, and if you feel there is any vitreous coming in, you can do a vitrectomy first and then put in your graft. In pediatric cases like in CHED, sometimes the cornea is quite edematous. You debride the epithelium. Younger than 8 years, I don't attempt to strip the decimates, but older than that, we do strip the decimates. Sometimes we do it under air. Here, the cornea is not that hazy because after removing that epithelium, visualization is okay. Did a surgical PI, that's why it's looking a little irregular because you pulled in too much of iris tissue, especially if the pupil is mid-dilated. And you wouldn't want to use a vitrector in a phakic eye because you have the crystalline lens behind or you might eat the zonules. The advantage in pediatric eyes is that the chamber tends to shallow very well. So you can get the graft to unfold very quickly. But flipping the graft can be a bit of a challenge because then you may have to suture the side ports and then deepen the chamber to flip the graft. So that's the patient post-op. So in CHED, you can find that DMEK works really well, and it doesn't add any stromal volume, unlike doing a DSEK in these eyes. Pull-through technique, yes, this is a one-eyed patient, other eye is blind. This eye also has had multiple trabeculectomy surgery, angle closure. You can see that he's pseudophakic, but his AC is completely flat. There are peripheral synechiae. Doing a DSEK is difficult because there is no space in the anterior chamber. He's short axial length. Doing a PKP also is more challenging. So we decided to go ahead and attempt a DMEK surgery. After debriding the epithelium, the visualization is a little better. So patiently do a synechial lysis. Don't be in a hurry because if you apply too much of pressure, sometimes you can tear the iris from the root. So try to avoid that. Gently release the synechiae, and then we did the decimate stripping. And I tried to put an air bubble in the anterior chamber, and you find that it's difficult to get an airfill in the anterior chamber. So went ahead through pars plana, did a limited pars plana anterior vitrectomy. This has been described in several papers from Japan where they have smaller eyes and or post-angle closure glaucoma where they do an anterior vitrectomy to increase the space. Then I went ahead and I trimmed the tube because it was too long and it would impede with my DMEK graft once it is placed into the eye. Again, I check. So here, instead of just shooting the graft into the eye, we tried to do the endo-in technique, just like the endoglide. And we prepared a slightly smaller graft because our available space is a little less. So we used a 7mm donor size. We used a pull-through technique, get the graft to unfold. But by this time, because we were irrigating the anterior chamber and everything, fluid went into the posterior segment because of the misdirection, and again the chamber became shallow. So I had to go in through the pars plana and again aspirate a little bit of fluid from and once we have done that, we were able to create the space in the anterior chamber, and then you can put in some 20% SF6 and use it for tamponade in this scenario. And you have to sometimes go ahead and push the tube down so that it covers So that's the same patient in the post-operative period. You can see that the DMEK graft has worked very well. The chamber is well formed. The synechiae fortunately did not recur. We are supposed to dance to Natu Natu now. That's the unfolding we could have done on that. DMEK dance on that. So yes, a lot of these complex scenarios, you can have, modifications which are necessary in difficult situations. You have to look at the available space in the anterior chamber, then plan the size of the donor, the technique of how you are going to insert, and whether you're going to use the flushing technique or you're going to use a pull-through technique. Sometimes in these kind of scenarios, maybe an ultra-thin DSEK would be a good alternative to performing a DMEK surgery. So you have to think about that. Intra, bleeding, fibrin, vitreous, all these remains a potential complication. And in certain cases where you feel that this might occur, it's always better to discuss with the patient and with the option that you might have to, do like a stage surgery. And if this happens, you have to manage that first and then go back. Sometimes we find subluxated lens as well. You have the vitreous, you go in, then you find that the lens is moving to one side, so you have to manage that. And so these are things that complex scenarios always tell the patient that there is a possibility that there may be a second intervention that may be necessary. Thank you for a patient hearing.
Thank you, sir. That was a beautiful collection of challenging situations in DMEK. I had one case in which I shot the graft into the eye. It went through the pupil, and I didn't realize that the lens also was sort of some subluxation was there. Through the zonules, it went straight into the vitreous. I went in, I was looking for my graft, it's just not there anywhere. And finally, post-operatively, I knew it must have gone into the vitreous, and sure enough, we dilated and saw the graft was floating in the vitreous.
So there's another video which was posted on Keranet where this guy had a similar situation, that he injected the graft into the anterior chamber. There was a PC break pre-existing, so some vitreous came into the anterior chamber. He just sutured the wound, and then to try and do some vitrectomy, he went with the infusion, and by the time he could put the vitrector, the graft had disappeared from the anterior chamber. The pressure of the fluid in the AC just made the graft go behind. More vitreous came forward and the graft just slipped behind. So I think in that kind of scenario, you can even sometimes pull the graft outside the eye. Hazim will tell you that he had cases where he had fibrin intraoperative and the graft scroll got caught in the fibrin. Fortunately for me, I have not yet had that kind of scenario. But he pulled a graft out of the eye, he teased the fibrin off the graft, restained the graft, put it back, put it into the eye, and completed the surgery, right?
That's very interesting.
Yeah, this video which you're talking about, I extracted the graft with the forceps. But nowadays, if I'm going to extract the graft, I just aspirate it inside the cannula. So you go with the infusion cannula, and then you aspirate so you don't tear the graft, and then you get it outside, and then you remove the fibrin from it, salvaging the DMEK tissue. Of course, the DMEK tissue won't survive that much, but at least it gives you some time till you prepare for another DMEK tissue coming from the bank, but at least the patient has some living endothelial cells to work for the cornea to avoid the corneal, the bullous keratopathy.
There is a published paper where the surgeons have put in the graft upside down, and 2 weeks later, they realized that it's upside down. They went back, detached the graft, brought it out, put it back inside the eye, and put it back, and it stayed. The cell counts were very low. There were only about 600 cells surviving, but the graft cleared.
It's from Melis group only, I think.
No, not from Melis group. This is from somewhere in Southeast Asia.
Okay.
They did that because they did not have access to another tissue, but they realized at the second week post-operative. So this is not immediate post-op. This is 2 weeks post-op. You realize that your graft is upside down. You detach it, take it out of the eye, and this was just a chance that they have taken. So if you're doing a DMEK surgery and on day 1, day 2, you do realize that the graft is upside down, I think based from the results of this paper, you can even detach it, bring it out, stain it, put it back.
You don't really have to do a repeat.
You don't have to,
I think that's a very good learning.
I've done that at 1 hour because I had a patient where I tried to put a stamp. Instead of a stamp, I put a map because my ink got smudged, so it was like a geographical map. And intraoperatively, I thought I had put it the right way. And for some reason, I had a doubt. I came back and I was reviewing the video. And while reviewing the surgical video, I realized that I put it upside down. And I usually see my patients 1 hour after surgery on slit lamp. So I told the patient, your graft is little displaced. I'm going to take you back to the OR and put it back okay. But I just took back OR. He still had some amount of local anesthesia. I just detached the graft, flipped it, put it back, and he did very well.
Nice to hear that. Yes.
My question to the panel and the Dr. Fogla. Sometimes we have those situations where you have a deep anterior chamber and an hypotenuse eye at the same time. So you open the graft with an air bubble inside the roll, like Isabella De Pena described. But once you remove the air bubble, it recoils again. Then you inject air, then it recoils again once you remove the air bubble. So do you have any kind of like tips and advice in such a condition?
There was I think one reference where I saw where they are putting a air bubble in the vitreous cavity. So the lens iris diaphragm is coming up by the air bubble what they put in the anterior vitreous.
You know what? I found that in such cases, when I have this roll, I just keep the air bubble inside the anterior chamber, and then I bring one of the surgical hand vitrectomy lenses. So
Yeah.
I press over the cornea, and once I press over the cornea, I withdraw the air, aspirate the air from inside the roll. It does not roll again because you're scaphoiding the cornea backward, and then through the same cannula go behind the membrane, and then you inject the air while you're releasing gradually the pressure with the handheld vitrectomy lens.
You can look on YouTube and see scleral contact lens associated DMEK. Scleral contact lens associated DMEK for the same purpose, because a scleral contact lens is a large lens, so they are using it to make these are for very deep chamber eyes, so they are using it to depress the cornea. So he's unfolding the graft by depressing the cornea using the scleral contact lens by not the right way, but he's using that to press the cornea down, just like you were using the lens for vitrectomy.
That's a fabulous tip, and I think very innovative, out of the box thinking. And it worked for you. Yes. Lovely. Thank you. So any other questions from the audience? We have about 5 minutes, 7 minutes.
Really great talk, sir. So my question was, sometimes the DMEK graft gets stuck in the angles, one of the edges. So how do you manage them and how to prevent that?
See, if you feel that your graft is getting stuck at the angle, you should immediately try to release it from the angle, because the longer you leave it there, it's going to get stuck. One way is that you go with your irrigating cannula and just try to flush it from the angle. If you irrigate, you will be able to release it from there. And always what I like to do is I like to do a circular motion on the cornea. So instead of just trying to bring it towards the center by tapping it, if you give it a swirling motion, like you are trying to twist the graft, you will find that it releases from the angle much better this way rather than trying to release it towards the center. And if nothing works, I go with the microforceps and I just pull the graft out of the angle. I connect my AC maintainer, run it slow. With the other port, I go with the AC with my microforceps, catch the edge of the DM, and just, because I don't want to leave it there. The longer it remains there, you will get fibrin, and then that part of the graft doesn't open.
Yes, there's another question.
In cases of bleeding from the peripheral iridectomy, before injection of the DMEK graft, Dr. Foglash was injecting air for 1 minute or 2 minutes till the bleeding stopped. Do you think that injection of triamcinolone after stopping of the bleeding and washing of the bleeding had a role in prevention of adhesions post-operatively?
Well, usually I would say that at least 50% of the time after you have done your inferior PI, there is some amount of bleeding. And I usually control that by giving a complete air fill and just wait for a minute or two. And then you go back. Just that when you're going back and washing out that anterior chamber or doing that, don't go to the inferior PI and try to do that, because if you do that, it'll again re-bleed from there. And somehow I have not encountered any post-operative fibrin or anything from that.
I have done a couple of cases where I have not done the PI intraoperatively.
Yeah, it's not necessary. My first 6 years of DMEK I did, and I have not done a PI.
And I went and yagged it on the first post-operative day itself on the slit lamp through the air bubble, and that works very well actually. So we could probably avoid this whole iris manipulation if you want to. Yeah. You
will convert soon, don't worry. It just takes you 1 or 2 cases with the pupillary block, and then you'll be back to saying, yes, I want to sleep peacefully, I want to live longer.
That's true.
Yeah.
Causes too much of pigment release. And
So there's a nice other technique of doing inferior PI, where you take they have shown in one of the ASCRS meeting only, they use a MVR knife. They come superiorly, they go through the center pupil, go inferiorly where the proposed site, and then they bring the MVR tip through the iris out. So that way you are, creating a linear slit in the inferior iris.
Interesting. Any other questions? Any questions from the other panelists? Any thoughts? Sir, any final closing
No, nothing.
comments?
I think plan your surgery well, because not every case will behave the same way.
Yeah.
Diameter of the graft is important. So the same diameter of the graft may look very small in certain eyes, and in certain eyes 8 millimeter will look like, oh, it's huge. So measure before you go ahead and prepare your graft, just measure the corneal diameter, or pre-op on slit lamp, just have an idea of what kind of ACD you are working with and what's the diameter of your graft, and then plan your donor size.
Thank you. There's one more comment. Yes. Two.
So I just had one query regarding the injectors, sir. Can we use the regular IOL, foldable IOL injectors, or should there be any modifications to that?
We'll let Siddharthan answer that.
So the only thing I use the white or limbus to limbus diameter in order to measure my DMEK tissue diameter, except in only one condition, in ICE syndrome, where there is 360 degrees of peripheral anterior synechia. I found that if I put a big graft and I cut all the synechia, the peripheral anterior synechia recur back. So I measure my diameter inside the diameter of the peripheral anterior synechia. Otherwise, it might endanger my graft and detach it later on.
Correct.
That's why do your surgery in ICE syndrome very early. So if I see a patient with ICE syndrome, I have a very detailed discussion with them and tell them that the disease will progress and you will have, so the sooner you replace your abnormal endothelium, the sooner you can modify the disease. So I don't wait treating them with 2 or 3 anti-glaucoma medication. I tell them this will definitely progress. So you do your surgery early, you will have much better long-term prognosis.
You want to just answer the previous question?
The thing is that I think nowadays many people use glass injector, but last 10 years I've been using only regular IOL cartridges. So it's just the technique. I don't think any cartridge makes a difference. Maybe I use a 2.8, or I don't use a larger cartridge, because the more the scroll, the lesser the touch to the because as I showed you, the endothelium is outside. So the more the scroll, it's better that the touch is less.
You're using the Alcon D cartridge.
I use the Technis cartridge.
Technis cartridge.
so in that cartridge part, you need to practice it a few times in the wet lab, because the connector, which is the rubber in between, which you will use, that connects the syringe with the cartridge. So usually in initial days, when you aspirate the graft, it will lie in that space. So if you aspirate it too much, it's gonna hit the syringe's narrow end. So you have to be careful there. Otherwise, it really works very well.
Try avoiding using a 5cc syringe and make sure your syringe is very smooth. Tacky syringes, you will find you aspirate and you will find the graft in the barrel of the syringe. It comes in very quickly. So using a 3 ml syringe is much better. And as he said, it's always better to practice first, so you know. And whenever you get your graft inside the injector and you want to adjust it, always take a bowl of fluid or petri dish and then just sit there, because without that, if you slightly move it, you might lose your graft coming out very easily.
So the cartridge is straight. The glass tube has an advantage, it's long and it's curved, so you have a lot of space to manipulate it by the time you inject it in AC. So cartridge definitely needs some practice.
We'll have one final question.
Any tips in, like, when you're injecting the grafts in the eyes which have the 4 to 5 mm fixed dilated pupil? Because I have 2 cases which directly went into the vitreous behind the eye and I'm not able to remove that.
You are very strong. That's why I use my technique. Connect an AC maintainer to keep it on when you're inserting your tip of the cartridge into the AC. Once it is into the AC, you rotate the injector so that the open end of the scroll is facing towards you. Then you switch off the AC maintainer. Ask your nurse to disconnect the AC maintainer from the IV tubing. Now what happens is your AC maintainer acts like an egress point of fluid going from out of the AC. That means your AC will never get deep. So now when you're injecting fluid, you don't have to apply too much pressure because the counter pressure is minimized. Normally what happens is if you don't apply sufficient pressure, only fluid goes in, the graft remains in the injector. So you want to give it a very firm push. Here what happens is because the counter pressure is not there, the fluid is going out from the AC maintainer, you will find that the moment you start injecting, the tissue will just glide into the AC. So you don't require too much of pressure. So then you need not, fear about going into the vitreous cavity. The second tip you can do is you can make your wound slightly bigger and your tip of the cartridge can cross the pupil.
Yes.
And then you start injecting your graft. Yes. So the graft comes onto the iris. Once the graft comes into the AC, you can gradually start withdrawing your tip. Because if you keep your tip of the inserter only in your wound and you inject, then sometimes it will just follow the fluid. So it can go through your pupil into the retropupillary space.
This is very important, sir. Very important point. Yes.
The graft will follow the fluid.
Especially in triple procedures, if the IOL tends, the diaphragm shifts upwards, and the likelihood you will put it in the pupil is very high.
So in complex scenarios, I do that. I cross the pupil and I slowly inject so that my graft is on the iris and then I come out, rather than trying to just flush it down.
Yeah, another point I was discussing with Dr. Rajesh is that we always talk about the tight scroll as a challenging scroll, but we never discuss the flat scrolls, the flat membranes, which they don't want to scroll. And his point of view is very valid. It acts in a very unusual way, so that it has some sort of an S pattern. So one part is rolled upward and the other one is rolled downward. And if you're trying to inject any fluid, then the one which was backward goes this way. So it's
and these grafts, if you have not marked, once you strip it and put it in the fluid, you will not know which side is,
because they don't curl. Yes. Thank you. I think we had a very nice interaction, even though the audience was not very big, but I think the hall is massive. So for a DMEK very focused session, it was very good and wonderful interaction. Thank everybody, the audience and the speakers for being part of this. Thank you.
Thank you. Thank you.